Welcome back to the Equine Anatomy lectures. I'm going to be working on the equine forelimb, continuing on it. And we've talked about the joints of this limb, the muscles of the limbs, the nerves of the limb, the passive stay apparatus of all shoulder, elbow, carpus, and fetlock joints. Then we've talked about a number of diseases, sole abscesses. We've talked about navicular disease and palmar digital neurectomy to treat it. And then we finished last time's lecture with talking about laminitis. So today we're going to be continuing on the topic of laminitis, and then we're going to go to a more general explanation, and that is the lameness exam. Okay, so we did talk about how laminitis takes place in two stages. The first one is we call foundering, and that is the separation between the internal lamina of the epidermis and the external lamina of the dermis. The loss of the interdigitation between the two laminae and the oozing of blood in the space between them, between these two laminae, is called laminitis. We also said that when the case is more advanced, there is a pull by the tendon of the deep digital flexor, a pull on P3, because it's the only tendon that reaches P3 on the palmar aspect. So the continuous pull will separate more P3 from the hoof wall, and that is what we call rotation of P3. Rotation of P3. This is shown here. The relation between P3 or the coffin bone and the hoof wall should be a parallel relationship. This is a parallel relationship. This intimate relationship caused by this interdigitation between the internal lamina of the epidermis and the external lamina of the dermis is lost due to systemic diseases, toxemia, bacteremia, septicemia, grain overload, post-parturition, trauma, you name it. You will get to this disease when you get to medicine and surgery. But for now, the loss of this interdigitation is caused by these diseases, will lead to separation between the two lamina and accumulation of blood in this space right here. This is laminitis or foundering. The stage 2 of this disease is called rotation of P3. Rotation of P3, which is due to the pull by the deep digital flexor tendon. Continuous pulling will pull the third phalanx or the coffin bone caudally, and this will make even the case more worse. As I said, it's a pretty harsh disease, and it ends with pretty grave prognosis, especially at this stage right here. Let's look at the case using radiographs. This is the normal relation between the hoof wall, which is here, and P3 or the coffin bone. See, this is the parallel relationship between them. In cases of rotation of P3, you can see that P3 is being pulled backward in the palmar direction and dorsal. Palmar and dorsal. If I can make it more clear, the P3, because of the pull, is coming all the way to that side. This is basically where the deep digital flexor tendon is pulling. So this parallel relation in the normal animal right here is lost. This parallel relation is lost, and P3, instead of this line here, it becomes here. So this angle right here is basically the angle of rotation. You can say it's a 20 degrees, you can say it's a 25 degrees angle, but this is called rotation. This is a diagnostic picture or radiograph of this disease. If we want to draw this separation and rotation, so 2 stages, separation and rotation, we are looking at a picture like this. In the mild cases, in the laminitis, in the foundering, we will have a little blood coming in between the hoof wall and the P3, which is the internal lamina of the epidermis and the external lamina of the dermis. Here, there is more blood, so in the moderate case, and in the severe case, we have the pull. You can see here the, let's see this is the deep digital flexor tendon right here. It's pulling on P3 because it's the only one that reaches P3, which is this one from the palmar side of the foot, so, or the digit. So this is an important concept here, and that's what we call rotation of P3. Rotation of P3. And now, with this, we conclude our discussion on laminitis. We need to see how the horse stand or walk. It's very painful. So this is basically how the horse stands on both feet and extremely reluctant to move. Extremely reluctant to move because it's very painful. The case is extremely painful. So okay. So we've talked about all the joints and muscles and tendons and nerves of the forelimb. Now we have to talk a little about, okay, well, the most important thing that, or clinical sign that we're going to see in limbs, both hind and forelimbs. And by the way, here I would like also to remind you that when we talk about the hind limb, we will not talk about the digit, which consists of the fetlock, pastern, coffin joint, and the metacarpus, because they're all the same in the hind limb and the forelimb. So the same diseases, the same structures. The only difference is the name. Palmar in the forelimb, plantar in the hind limb here, and metacarpus 2, 3, and 4, medial to lateral respectively. Here we call them metatarsus. That's all. 2, 3, and 4 medial to lateral, respectively. So basically, from metatarsus down, I'm not going to be talking about when I talk about the hind limb. It's exactly the same as in here. I will only be talking about the hip, the stifle joint, and the hock joint. So 3 joints. The last 3 joints in the hind limbs, I'm not going to be talking about. So back again to the discussion of the forelimb, and also which applies to the hind limb as well, by the way. The most prevalent clinical case that you will see in limbs is lameness. I mean, the horse is standing on its 4 feet, and therefore any problem with these feet will basically reveal itself to us as clinicians as lameness. So how are we going to examine the horse for lameness? There's a systematic procedure to do that, and we have to understand that we have to do things in a chronological order so we can actually build a story rather than collect pieces of information here and there, which will not, for the most part, lead us to a diagnosis. When we do it systematically, usually we end up with a pretty good idea of what's going on. So how we do a lameness exam? Okay, so there are a number of points that we need to remember when we do a lameness exam. First of all, we have to do we have to get a pretty detailed and precise case history. Everything, all the way from vaccination and deworming to when did you see it, the age, the breed, the everything about the patient, about the horse, basically. And after that, we have to do a complete physical exam. So do not underestimate the effect of your stethoscope or your hands when you touch the lesion and see what's going on, if it's painful or not, if it's warm or not, things like that, to show inflammation or to show acuteness versus chronic stage and things like that. So you have to understand that a complete case history and a complete physical exam are extremely important in making a diagnosis. And by the way, most of the diagnosis usually comes from the case history. From if with experience, of course, usually the case history is the one that tells you what's going on with the animal. After that, we do some hoof investigation. Since we start, as I mentioned, systematically, we're going to start from the ground up. We don't start from the head down. We start from the ground up. Okay, so we go with the hoof first, and then we see if they're well cared for or not, and then we're going to watch the horse walking, trotting, jogging, whatever the horse is used to do. That's what we want to do, to look at the horse doing, because that's where the problem is. If the horse is a race horse, and you're telling them, okay, I'm going to take him in an elevated area or a slope and things like that. Okay, well, that comes later, but to start with, you have to understand first what's the function, what's the job, what does this horse do for living. That's the most important part. And then after that, you continue your exam. Then you palpate, you put your hands on it, on the hoof, and you see where the lesion is. You palpate, you utilize your hand, your sensation to find all of the structures, if they are doing well, or there are some swellings, there are some heat, there are some pain, there are things like that. So you have to know this. And by the way, all of this you will get it when you get to medicine and surgery, but this is as an introductory information, if you will. Then you get to the hoof testing, and hoof testing is extremely important because basically you will localize the lesions that you studied in anatomy. Here we said the hoof consists of wall, sole, and frog, and the wall consists of a toe, quarters, and heels, and the frog consists of an apex and heels as well, and the sole is covering the whole area except the frog. So we have to know which area basically is painful and what are the structures underneath that area, navicular bone, P3, etc. So all of this needs to be investigated with a hoof tester, and then we do some flexion tests, again systematically, ground up. So we start with the coffin, pastern and fetlock, and then carpus, and then elbow, and then shoulder. We don't start with the shoulder and leave the digit for the end. And then we do nerve and joint blocks. And then after that, we go with the most expensive method, and that is imaging, basically. So you start with the basics, and then you go all the way to the most sophisticated methods on diagnosis. So let's see how first we're gonna see how we're gonna look for the hoof care and things like that. So when a clinician is looking at the horse's hoof, basically you see if it's clean or not, and if there's any lesions. And main thing we need to see if the hoofs are there's a shoes or not, and sometimes we need to take the shoes out and to see the horse without a shoes and walking and jogging and trotting without shoes, and sometimes we just keep them. The most important thing is to make sure that the sole and the frog and the other structures of the hoof are basically clean and clear from any lesions. And please remember that you use this brush that's attached to the hoof knife and to the hoof pick, and you clean it, and then you clean the area with the hoof knife, and to make sure that there's no abscesses and things like that, no infections, no invasion by any hard object, things like nails, stones, sharp objects, etc. That goes through the sole or the frog toward P3 or the navicular bone or the deep digital flexor tendon. Remember that 90% of your non-weight bearing acute, not non-weight bearing lamenesses are basically due to sole abscesses. So basically, be very careful to rule out this case, and make sure that it is the hoof wall, sole, and frog are clean from any lesions. Now, next we do the hoof angle. This is a machine that tests the angle of the hoof wall, and usually in the forelimbs it's about 45 degrees. It'll be a little more in the hind limbs, about 48, sometimes even to 52, depending on the breed and the type of the work that the horse is doing. But usually it's about 45 in the front limbs, in the front hoofs, basically. So that's a very important thing, because if there are some lesions, or some types of lamenesses are based or as a result of bad shoeing or bad hoof trimming. So we need to make sure that everything is clean and clear, and the angles are correct before we dive into the hardcore medicine, if you will. So hoof angle is a very important thing. And then we mentioned that you need to start palpating the different structures. For example, this picture shows and I told you earlier, we need to understand the structures of skin to skin, from the dorsal to the ventral aspect of the for example, the metacarpus. Skin to skin, you have the tendon of the common digital extensor. You have then the cannon bone, and then you have the splint bones 2, 3, and 4, medial to lateral respectively, and then you have the suspensory apparatus, and then you have the deep digital flexor, and then you have the superficial digital flexor. You can feel these by your hand. They're not they're not something in the textbooks only. No, you have to feel them. You have to separate them with your hand, like what this clinician is doing. And once you do that, you make sure that there's no lesions, no swellings, no heat, no pain that the horse is showing, or you can feel in any of these lesions before you dive into ultrasound and things like that. After that, you go with the hoof testing. This is two types of hoof testers. Basically, a nice pair of pliers, if you will, but and you put them at different areas in the hoof wall, and you start applying some pressure. And when you apply this pressure, you also feel what the horse is doing. If the horse is flinging, if the horse is moving quickly from when you put some pressure, then that is a painful area. So you have to be very careful about applying your hoof testers. This is another picture showing different areas of testing different regions of the hoof. So here the pressure is basically on the quarters and on the sole. Here it's on the toe. Here or on the heels, and so on and so forth. So the hoof testing must be done systematically and regional, so you understand which region or which structure basically is underneath that area that you are pressing. So for example, this is just an example. If you're putting pressure here at the toe area of the hoof wall, I hope you don't expect that the navicular bone is located here, because it's not. What you're pressing here is on P3 only. Okay, in this area, in this case, on both heels, and you're pressing, of course the navicular bone is residing right here. And when you put some pressure here, that means you are testing for that hoof for that navicular bone. Things like that. Here you are basically taking the quarters, and this is only a part for P3. So again, regional testing is an extremely important thing to do. After we do that, we go with the flexion tests. This is again systematic. You have to start ground up. Remember that. So first of all, you have to flex the coffin, pastern, and fetlock together. Sometimes you flex each one separately. If you are suspicious about a problem in the fetlock, in the coffin, then you have to go with the coffin first, and then with the fetlock, and so on and so forth. And what when you do that, and then of course you go with the other joints. Like for example, here we're doing the carpus flexion. In this picture, we are doing the elbow flexions and things like that. And the reason why we do that, well, first of all, what we do is basically, when we start from the beginning, what we do is we apply pressure on that joint when we flex it. So we basically exacerbate the pain, increase the pain of that particular joint. We do that for about a minute or two, and then we let the horse run. The person who's holding the horse will tell him, okay, well, go run now. And then we will see if the pain caused more lameness or not. If the pain from the flexion, if the pain that results from the flexion caused more lameness, that means you've localized the problem. The problem is in that particular joint, where you actually put more pressure, where you increase the pain in that joint. Now, if you do the flexion and the horse is still as is, then probably your pressure did not do anything. Now, please realize here also a little note then, that when you do the flexion test of the joint at the very, very, very beginning, and that comes with experience, that the very beginning you will see that the horse is a little lame, of course, from the pain. But does that mean that this particular joint that you flexed is the problem? Well, if the lameness continued for the whole minute or two when the horse is running, then yes, this is the problem. If the lameness only lasted for a few seconds after you let the horse run, and then the horse started to go normal, then it's not the problem. So you have to go and find another joint to flex, basically. And again, I keep repeating that. Systematically, you have to do things, and then you have to start from the ground up. From the ground up. That's very important. After we do joint flexions, we come to the very important technique, and that is nerve blocks. Nerve blocks is a very important technique that we utilize to localize the lesion. And just as we did flexion of the joints systematically from the ground up, we also do nerve blocks systematically from the ground up. Very, very important. Very important. Very important. Now, what I will do now is I'm going to mention the nerves in general, and then next time I will repeat the nerves and state the different nerve blocks that we will apply to localize the lameness. Okay, so the nerves supplying the forelimb are the median nerve on the medial side of the forelimb and the ulnar nerve on the lateral side of the forelimb. Now, at the level of the carpus, the median nerve gives two branches. First, the medial palmar, and then the lateral palmar nerves. At the ulnar nerve, on the other hand, gives two branches, the dorsal branch, and the palmar branch. Dorsal branch and palmar branch. At the mid-carpal level, the medial palmar gives a communicating branch that joins the lateral palmar. So this is the communicating branch, joins the lateral palmar, and the medial palmar continues as medial palmar all the way until the fetlock to become the medial palmar digital. It's the same nerve, medial palmar digital, and it gives the dorsal branch also at the level of the fetlock. The lateral palmar continues as a lateral palmar digital at the level of the fetlock, and also it becomes the lateral palmar digital and gives a dorsal branch. These nerves, we will talk about them extensively even more. The most important thing to remember is that the median and the ulnar are supplying the forelimb on the medial and on the lateral aspect of the limb respectively. And again, next time we will talk about that in details, and we'll continue on the nerve blocks.